Hello, everyone. Welcome to UIC virtually. We'll get started in just a few minutes. Just make sure everyone can hear. You're okay? Give us a thumbs up if you can hear us.
Or Kit, can you hear us?
Yeah, I can hear you.
Yeah.
You guys can start. Go ahead.
Good afternoon, everyone. Welcome to UIC. I'm Jeff Taylor. This Suji Velgapudi. We're going to be presenting a case today. We have some of our faculty in the room as well. Maybe you guys can introduce yourself, please.
Rubén Rodriguez, the program director.
Khalil Ibrahim, one of the associate program directors, interventional cardiologist.
I'm Ardati, interventional cardiologist.
We have some of our fellow.
I'm Josh, I'm a first year fellow.
All right, so we'll go ahead and get started. So we have a 59-year-old gentleman who presented with syncope leading to an orbital blowout fracture. Was actually transferred to our institution initially just for evaluation by ophthalmology because of this orbital blowout fracture. And so talking with the patient and working up his syncope, he mentioned that he's a pretty active guy who walks every day, and that this day that led to his presentation, he was walking up just a gentle incline and started feeling dizzy, turned around and was about to head back towards his house, and then he lost consciousness. In terms of his history, he does have a history of hypertension, hyperlipidemia, sleep apnea, a bicuspid aortic valve, and an anomalous left main coronary artery. And in terms of his vital signs, you can see in the bottom right there, he's a little hypertensive, heart rate 98. Otherwise, he's on room air, breathing comfortably. And so in terms of physical exam, obviously his face is very impressive with this orbital fracture, lots of swelling around his face. He does have a holosystolic ejection murmur that's heard best on the right upper sternal border. But otherwise, on his physical exam, pretty unremarkable. Lungs are clear. Doesn't have any lower extremity swelling. And in terms of labs that are notable, he did have a mild elevation in his high sensitivity troponin. His white count was 13. His hemoglobin was 16, which is normal. And he does have this history of a cardiac CT, which found this anomalous origin of the left main coronary artery from the right coronary cusp with an intra-arterial force. And so just touching on that briefly, he did have an episode of chest pain that was believed to be non-cardiac that he presented to an emergency room back in 2022, which led to this workup for a cardiac CT. But because he was a functionally active guy, there was no additional workup at that time, and he was following outpatient with a cardiologist. So our EKG on admission, maybe I can have one of our EP doctors just take a brief look through this. We don't really see anything.
All right, Josh, go ahead. All right, so from a first year fellow's perspective, looking at the CKG, it looks like it's normal sinus rhythm. It's close to tachycardic. I don't see any prolongation in any intervals, particularly. The axis looks like it's normal. Heart rate progression, no SCT wave changes associated with.
On B1, you want to comment now?
I would say, yeah, B1 looks a little bit, I guess, elevated.
But what specifically do you want to? Can you? So if you're looking
Had
at
that ST elevation.
what are you thinking of at this stage?
I do. Reduce needs. Some not consistently across the.
But let me ask you this.
Brugada is your other possible Brugada.
So, but how about this? Let me just put a scenario. It's 3 a.m. It's chest pain. And you look at AVR, there's ST elevation in AVR, and you have ST depressions and everywhere else. And the heart usually points towards the left, and the right doesn't point towards the right. Right? So it seems that horses are going away, like life's going away. It's pointing up in the AVR and down everywhere else. So this is generally bad in intervention. And again, with some clinical scenario, right? But I mean, chest pain in this,
Yes.
I would hyperact this. Sure. Because you have a lot of ST depression. They're kind of nice and horizontal. They're not svelte.
And so thankfully he was not having any chest pain at this point. And so initially, as we mentioned, he was here primarily for this eye evaluation. So he was being seen by ENT ophthalmology. They started him on high dose steroids, but there was no plan for any surgical intervention. So kind of just with maybe our fellows, kind of what are our thoughts for next steps for someone presenting with syncope? Syncope with exit.
With the senior fellows.
Well, yeah, for
Sorry,
syncope.
I'm just at the beginning part of the case, but it's not the data.
No. You want to just summarize this history for the fellows that came in late?
The gentleman who has a known history of anomalous coronary artery, who presented with syncope with insertion and had an orbital blowout fracture and a bicuspid.
And he's got a history of bicuspid
Yeah, this is.
and no ascending aortic dilatation or anything like that.
I think I was involved in the paper. So it feels a little unfair, but I would start with an endo. And then genetic EKG, some blood work.
So we decided to get an echo next.
So at this point, we had this history of this coronary, and so it was very able to start with evaluating the aortic valve. So we have a baseline echo on left side of the screen. This is the standard Palestine long axis view, where we see that the LV is squeezing well, the walls are approximating, and on the right side of the screen, we do see it's a little bit zoomed in view of the same Palestine long axis. So in order to see how the aortic valve is looking, given that it's bicuspid, we were expecting to see some calcification. We do see that it's calcified, but it seems to be opening. It's not the best image for us to evaluate more than except for telling that it's calcified. So coming to the other views, this is color Doppler of the Palestine long axis. So on the left side of the screen, we are trying to see if there is how the flow is in the LVOT. And I just have a still image on the right side. So we do see some flow acceleration in the LVOT. This color change from blue to yellow to red, this is kind of aliasing, and there was some concern for flow acceleration in the LVOT. Again, so this LV appears kind of hyperdynamic, and we do see some flow acceleration in the LVOT. We don't know where it's coming from at this point because it's just not. We have parasternal short axis view. Here we do see the, again, it's not the best, but we do see the aortic valve, it's opening. Probably there is some fusion here between right and left cusps, but not the best picture. And this is our apical four-chamber view. Again, we are trying to see that LV function. It appears good, indeed, a bit hyperdynamic. And RV looks good, normal in size with normal function. This is five-chamber view from the apex. Here we are trying to see the LVT and the aortic valve. Probably a little calcifying, not much information other than that, but we do see that the chamber is functioning like it's kind of the walls are approximating. And this three-chamber view, we see that little bit of flow acceleration again here when it's almost at the LVOT. So we'll go to our Doppler signals, which is going to give us a better answer about kind of a direction about where this flow acceleration is kind of happening. If it's at the valve or below the valve, that's one thing we're trying to understand after that LVOT, parasternal long axis view. And so this is what we saw on the continuous wave Doppler from the four-chamber view. So here, just going over the Doppler signal briefly, we do see a Doppler signal with a velocity of almost around 3. And there are two types of Doppler here. One, which is nice and round, and there's another signal which is underneath the nice and round signal, which is like late peaking. We call this early peaking signal, and this is a late peaking signal. So for the candidate, this is how. Now, what this means is this nice and round signal here, early peaking signal, is usually concerning for a fixed obstruction when it's above 2 meters per second, and it's almost 3 here. And this late peaking signal is concerning for a dynamic obstruction. Fixed obstruction, usually we have a couple of differentials, and for dynamic, we have a couple, we go over them. So
just briefly on this past page, so you actually, you mentioned about 3 meters per second. So can you tell what the gradient is for the fixed or for the dynamic obstruction?
So we can probably comment on the gradient here. So the gradient is going to be, it's 4v squared, so 930.
Gradient, that's still accurate in the sequential obstructions.
It's not. So when you have two sequential, when you have two areas of stenosis in series, then you can't, it's not additive. So you can't tell which one is the one. I noticed one other thing in your first, I don't know if you can go back to the parasternal long axis, it was very minor finding. But if you look at the, before the color flow, you can actually see that there appears to be dullning of the aortic valve leaflets. And that's frequently seen with the bicuspid aortic valve. So there are two things that can give you dullning. One is dramatic heart disease, and the other is bicuspid valve. So when you see that, you should think of those two things.
So at this point, yes, as Dr. Richardson that here, we know that we see flow acceleration, we see a peak velocity of almost 3, but we don't know if it's exactly coming from the valve, what part of this velocity is coming from the valve, versus given that we saw some LVOT flow acceleration, we're just wondering what part of that is coming from the LVOT by itself. Just for the candidates, so dynamic obstruction, the LVOT is usually a late peaking signal. This is how a Doppler signal is going to appear. Whereas fixed obstruction, which we usually see with aortic stenosis or any subvalvular membranes, it's more rounded profile of the velocity. So just going back one step, we do see both kinds here. We see a rounded signal as well as the late. So at this point, we were trying to understand where exactly this late peaking signal, which is the subvalvular obstruction, at which level in the LV is coming. So the text started pulsing from the mid ventricle. See what the velocity there is. It's about 1.6. It's not really high. It's 10 there. And then coming a little bit more proximal, it's around 12. So here it was almost around 1.6 at the LVOT, but the peak when we just put a continuous wave doctor, the peak signal that we were able to see, the late peaking velocity, the maximum velocity we were able to see is 2.4 with peak gradient of. So coming to just going over the findings from the echo, we did see a hyperdynamic left ventricular function with an LVF of nearly greater than 75%. Some moderate LVH on the echo. And there we saw the turbulence in the LVOT with the peak gradient of anything above 30 is more significant. And we could only tell the aortic valve appears moderately sclerotic. As Dr. Topert mentioned, we were not able to quantify the valve degree of stenosis because it appeared to be a sequential stenosis, so it's hard to quantify the stenosis.
So we took them for, we wanted to get basic hemodynamics in addition to, given our EKG changes, we wanted to make sure, knowing that this person has an anomalous coronary based on the CT, is there any evidence of obstruction? Do they have any bridging? Or we know they have this intra-arterial force. Is that causing some signs of obstruction? And if you look in the image on the right, kind of gives you a nice view of the left main, along the left main coronary artery. So we're engaged via a right radial artery with a Tiger catheter. And we came off the right cusp and we're injecting into the left main. And you can see, kind of, look at the left main, it's squeezing. And you're concerned that possibly, the pulmonary artery and the aorta could be obstructing this, or there could be some intramuscular course as well. All right, so you can see large caliber arteries. We really don't see any evidence of coronary artery disease. And you also see that we have a large circumflex artery and a smaller LAD. You can see it wraps all the way down to the apex. Show you guys a picture of the right as well. So you have a large right coronary artery, gives off large PL branch and PDA that also supplies a very large portion of that distal apex as well. So angiographically, we don't see any clear obstructions, but certainly very concerning left main that artery is kind of collapsing. The next thing we do is we want to get the hemodynamics. And so we're getting pressures in the aorta as well as the left ventricle. And we saw, so the patient ended up having some PVCs during the procedure, and we saw what's called this Brockenborough-Bronwald-Morrow sign. So we saw a large change in that LVOT gradient. So this gives you a really nice example of what happens after a patient that you're concerned for LVOT obstruction has, if you're concerned, then when they have PVCs, you see a large change in that left ventricular hemodynamic tracing as well as the aortic tracing. So you'll see the AO is going to, the aortic pressure is going to go down, and the left ventricular pressure is going to go really high after PVC because you have that decreased afterload, and you have you're going to have increased contractility after the compensatory pause from PVC, and so that will lead to that large change in the gradient across the aorta because of this LVOT obstruction. And that's something that we can't really see with the echo. So kind of seeing these two things, we then we're kind of thinking about our differential for this patient. And we can go out to the group. You know, we've now seen his coronary angiogram. We've seen his baseline TTE. He's a gentleman who had exertional syncope. Kind of, you know, what are you guys thinking could be the cause? It's definitely a little bit challenging, I'll say, in this scenario.
Instruction.
Yes, certainly.
So one explanation would be the dynamic of the obstruction. Another with that left wing's causing ischemia and VT because of that. And I don't know how you can kind of move one over the other in this situation. More than could cause it. Is what I agree.
Concern for severe aortic
Yeah,
stenosis as well.
severe aortic stenosis. Get a better idea of what the scalp thing.
Could also be multifactorial, all these different things acting together.
Yeah. I mean, and every is that thing that we're thinking as well, for multiple reasons as well, like BPVF.
Yes, so we did some additional testing in order to continue to work them up. And so, you know, big things that were on our differential is that this was potentially multimodality, multiple issues coming together caused this. And again, you know, patient wasn't wearing a monitor when this happened, so we don't know if there was some type of arrhythmia that caused him to syncopate as well. So we did end up during this admission getting a cardiac CT. And so as we go through this, we really see how calcified the aortic valve is, and you can see that it's bicuspid. And you can see, well, right there, you can see the right cusp. You can see where that left main comes off that right coronary cusp right next to the RCA. And we can see it's going to take this intra-arterial course. Actually, it's also going to go intramuscular. Yeah. And so that was something that we did not appreciate or had not been mentioned on his prior cardiac CT. And so these are kind of two concerning findings that this could have been, you know, part of the cause for him to syncopate and something that would need to be acted on.
It also looks like an acute takeoff. This is what we need to mention.
Yeah.
So yeah, you see this kind of sharp angle as well right through here. And so it's something that definitely will need to be dealt with. And so I just wanted to, for the trainees, just to give you guys a brief kind of overview of the anomalous course of the coronaries and features that can be, you know, malignant for patients. So a big thing is the intra-arterial course. If you have osteal tightness of that anomalous artery or an acute takeoff angle, these would all be reasons that you may need to intervene in this lesion. Other things that can occur is myocardial bridging, coronary artery aneurysm, fistula. And you kind of see up top here, so in this middle screen, this is kind of what we're thinking of our patients having this left main come off the right coronary cusp, and it's going between that aorta and the pulmonary artery. So then these are just some examples. You can have congenital atresia of the left main, and you could have an anomalous coronary off the pulmonary artery. So this is something definitely higher differential, but we still needed to work the patient up a bit more. I wanted to get a better evaluation of that aortic valve and the LVOT, so we did send the patient for a TEE next.
Well, but just before we get to TEE, so how high risk? I think that so how high risk is using your criteria. So the vessel
we have an acute takeoff angle. We have an intra-arterial course and an intramuscular course. There are three major things that would be a reason to act on this.
So you're right, hypothesis of these cases, this is what the cost of what patient syncophies is probably, you know, you just have prolapse of the artery or compression sort of the artery, and then you probably have some type of arrhythmia. Probably. So that's possible.
Yeah, so part of the reason at this point, we're thinking the patient's now going to need surgery to correct this. And so if they're going to get a procedure, we need to make sure that we don't correct other issues that he has, including this aortic valve, as well as possibly this potential LVOT obstruction. So that's what we want to evaluate.
I'll just make one quick comment is that, well, this is a great paper in a great journal. This is the upside down thing every single, right?
Oh, yeah.
If you look at the middle image, you should look at the mirror. So this is I don't know why they publish stuff like this, because this is not what you're looking at, right? From any meaningful projection, right? So, because if you look at the middle image on our CT, it was that upside down, right? Pulmonary arteries anterior, right still on the right, but still there.
So we moved on to our TE.
Yeah, just summarizing at this point, we knew that, coronary is potential radiology, and now aortic stenosis wise, we will have to see which would cast for around 3,800, which is pointing to severe aortic stenosis, because we were having problems with grading the aortic stenosis severity on echo. This is one of the helpful tools for us, which kind of differentiated, okay, this aortic valve also probably needs intervention. When he goes into surgery for the
It's not just the aortic valve, so specifically in this echo to localize the obstruction. So number one, we're fully not sure based on the transthoracic if there's any obstruction. Number two, we do not know the severity of it, which is really high. So let's just talk about this T. So planning to go into this T, what is your kind of, how are you, and this is for the more senior fellows, how do you optimize your chance of success in this T? A couple of things that I can do. So one, this patient is probably a little bit hypovolemic, so make sure they're very euvolemic before going to this echo. Otherwise, you're going to continue to have a very hyperdynamic T. Okay. And then when you're doing this procedure, the questions that we want to ask, is happening at the level of mitral valve, LVOT, view. So going into it, right, first year to second year fellows, what views do we really want to focus on after this?
Maybe like a breaking review. You can get also shows.
See what mid-esophageal 4-chamber, 5-chamber, 3-chamber. Not a 5-chamber. You essentially want the first thing that you do is you want to get mid-esophageal. Put the probe down. How many equals of 0? You want to start going in and out after you get your initial shoulders. Right? See how well you get the LVOT. You really want to maximize it. So when you're, and this, I did this echo, so you want to optimize your fragrance. And we keep talking about this. So you want to reduce your depth, esophageal, start at 0, narrow your septal width, and make sure that you're getting the biggest frame. Because what you want to see, and we're looking at, well, let me ask this. So we're talking about potentially a dynamic LVOT obstruction. So hypertrophic cardiomyopathy can be in play. Why does a dynamic LVOT obstruction happen?
It's some SAM.
From SAM, right? So you want to evaluate if there's. So you want to get long clips. You want multiple cycles. You're going to open up that heat acquisition, could be 5, 6, 8, 20 beats, whatever. You decrease your sector width, like we talked about, decrease your depth, get your frame rates to somewhere. If it's non-color, at about 100 to 120. If it's color, you want to be between 40 and 60 hertz. And then take long clips, because you want to see where the turbulent flow begins. One, you're going to look directly at 2D measurements. So do not do color comparison, right? Get 120 frames per second and see just what's going on with the flow. They see what's going on with the intravenous. If you see SAM, you visualize it. You can even do M-mode here, which we did. And then you know, oh yeah, well, this is definitely it. Then do color. and then do color compare. And then obviously you'll go transgastric, try to repeat and do the same thing. And it won't look pretty bad.
So, we involve the TTE, mainly we are trying to differentiate, we are trying to understand where that subvalvular flow acceleration or the dynamic obstruction is. So is it like mid-ventricle versus LVOT? So here we do see, when I play the image, on the first couple of views, we do see that the chordae is coming into the LVOT system. So that is one of the reasons why around the same location we see this flow acceleration. So we do see some signs of dynamic obstruction because of chordae coming into the LVOT system. And this is another view of the LVOT. Here we see that a little bit better, where the chordae is kind of getting sucked into the LVOT system. And parallelly, we see flow acceleration bounce.
Yeah, it wasn't actually, if you pause, it was difficult to fully localize what was happening right at that. Because again, portal SAM is not going to cause it anymore.
Yeah.
SAM will cause it. And when we were doing this, and I believe just about everybody was in this case at some point during this, it's not conclusive. So here in this, it did. So there was a hint that this may be SAM. But there, you don't clearly see SAM itself. You see portals. That was the trick.
This is not typical, as Dr. Gold mentioned, that to see that would be a gradient from portal SAM, but we did see flow acceleration around the same point. So it was pointing out it was probably this one.
It suggested other SAM,
yeah,
but not conclusive.
This is short axis image of the aortic valve. Again, a 3D picture showing again bicuspid valve. We were trying to get parliamentary areas as well. So this is another image. This is transgastric view. We are trying to get Dopplers across the aortic valve from a transgastric view. And similar thing, we see a better flow profile compared to TT. We do see a nice rounded flow of reaching about 4.5 meters per second, and also late peaking, nice dense jet here, which is our LVOT obstruction signal that we saw. So here we did know that there was the gradient across this LVOT valve. It's coming from both from the LVOT dynamic obstruction as well as the valve itself, because of the two different flow profiles that we saw. So at this point, so the way that TT helped us with the differentials is one, we did see the LVOT caudal SAM, and which could be a potential reason for the dynamic obstruction. We did see a better flow profile where we saw a jet reaching about 4.5 centimeters in the aortic valve. So here, as we already knew, the anomalous left coronary is an etiology for a CT. At this point, the aortic stenosis severity is severe based on calcium score as well as peak velocity that we got. Again, peak velocity, there is some discussion about a part of it is coming from the LVOT flow acceleration as well, but I think we do have enough evidence at this point to call the aortic valve severe stenosis. And we did see this caudal SAM. Again, as Dr. Pulish mentioned, it was suggestive of, but not conclusive, for us to get a better understanding about how the septum, how thick the septum was, and if there was any other signs of hypertrophic cardiomyopathy. The next best step that we decided to do was cardiac MRI to help differentiate that. So these are a couple of cardiac MRI pictures. Yeah. So here we do see the image on the left. We do see a nice coronary artery going intramuscular on one of the short axis cross sections. This is the intramuscular course of the left knee. And on the right, we see the left and the right cusps of the aortic valve are fused, and it's clear cut by this valve. This is a three-chamber view of the cardiac infarct, which did show the septum is very big. It was almost 2.5 centimeters. And sometimes we do see flow acceleration at the LVOT on cardiac MRI as well. This case is not as classic, but it mainly helps us to understand that the septum is very big. And on the late gadolinium enhancement, again, not the best pictures for LGE, but we did see some LGE at the anterolateral around base, around here, and also some in the anterior and inferior walls. Overall, with the septal thickness, with our TTE showing some obstruction in the LVOT and also some gadolinium on the cardiac MRI, at this point, we were able to tell that patient is without cardiac myopathy.
I guess a question for the EPs, if he just had the hypertrophic cardiomyopathy, without the other things, would he make criteria for ICD?
With that level of hypertrophy and then evidence of gadolinium, you'd probably be already at the 2B to 2A range for the ICD. It would come down to whether you felt that by history it could possibly represent arrhythmic, and that's to say nothing of the interarterial flows. So I think that he'd probably have earned himself based on
even if you fix everything else.
I think that's right. I think it'd be once you bring the bowel with this and you have an arrhythmic etiology that is definitely explanatory. Unless you proved it was one of the other etiologies that you can address, I think it's hard. A lot of times, if I was to approach this and the person is adamantly against an ICD, I would propose long-term monitoring at the very least. With the reporter, you kind of have to have a discussion with patients about their risk profile and their preference for ICD. But I think the other evidence that will warrant consideration.
Just to take a step back before that, so why was it so critical that we diagnosed this? I think there was probably two, maybe three big reasons. So one of them is the ICD. What is the second big reason that we need this? Especially with those.
Let me exposure to the OR.
So that procedure then gets much more. So here you're talking about unroofing of the left main, potentially the stenosis of the left main. Then you're talking about irregularity. So we're going to talk about HCM actively, and it's much more complicated. So you gotta get that diagnosis now because
One other random question though, is this guy just really unlucky to have all these different, or is there any kind of genetic thing that ties this all together? As being a non-genetic expert.
I mean, embryologically speaking, they have like similar, like the microscopic aortic valve and the left coronary artery, they have similar embryological, where they come from basically. So I guess that was very unlucky, I would say, but the genetics is on top of that. I don't think he had any family history for what I remember when I talked to him. So
he did genetic testing on that. He got great soon. I think it was success.
Speaking of species, right? Yes.
Again, that's very, very unusual. Yeah, it's not a classical late onset hypertrophic cardiomyopathy either. Yeah.
He does have family member with microscopic aortic valve. I think with the sister of the brother, somebody else had microscopic, but not ACM. I can't remember we asked about.
And this is an unusual presentation for late onset hypertrophic cardiomyopathy. To be so relatively benign with valve. Classically, you see that full T rate changes, which is associated with late onset. The other important thing actually for this patient is performing this is a cascade screen. Like Dr. Topoli mentioned, CN and on testing, you almost certainly should undergo testing for the first in CM there will be other family members who something will happen. We should be able to-
So ultimately, kind of as we said, he was planned to go to, he was evaluated by cardiothoracic surgery, planned to get a surgical aortic valve replacement. There was discussion between mechanical and bioprosthetic. Ultimately, they landed on bioprosthetic valve. And then he got a 2-vessel cabbage, he got a to his LAD, and then he got SVG as well to his cert. And then there was discussion on this septal myomectomy based on everything that we've seen so far. And I included the guidelines as well in terms of whether or not if someone's going for surgery, if they would get a septal ablation or a myomectomy. And since he was going to surgery, that was the plan. And so kind of interesting, once they were intra-procedure, they really wanted us to evaluate that LVOT more time while he was intra-procedure. And
here procedure between they were basically the key procedure and the LVOT as well as the procedure. So just before starting when the patient is in the OR, we did another evaluation to see if now because there's consent for HCM, we optimized his fluid status, he was on beta blockers, so he was medically optimized, and we repeated the T. And we no longer see that late peaking dagger kind of signal that we saw on the previous ECHO and as well as the TPP. And now with optimization, we don't see that extreme flow acceleration in the LVOT as well as the late peaking signal has disappeared. So at this point, we were like, it's already a complex surgery, fluid bypass along with aortic valve replacement. From the HCM standpoint, he is with medical management, his gradient improved. Probably once that gradient improved, now the flow profile, which is suggestive of the aortic stenosis, it was still almost 4. So probably his symptoms were coming more so from the aortic stenosis, also component of HCM along with pulmonary are always a concern. So we went ahead and decided not to do septal myomectomy, and patient got the 2-well cabbage along with aortic valve replacement.
Out of the box question. So in the past, one would have considered doing an alcohol septal ablation. Do we have any idea what artery actually was? And would we have him bypassing him at the sort of flow to the septum in the way that he might have these things? I'd go back and look at the picture and see where that's
very challenging to tell. You certainly see a septal off of his LAD. It's very tiny little branch there, but there's no. You see something coming off the main.
Yeah, proximal. That's very tough to do a septal ablation. It's almost like a spider web of small arteries and not.
Never mind.
Did they unroof and then reimplant his left knee, or did they?
They didn't do it because of the intramuscular. I think that was going to be.
That was in the other option.
Yeah. And it was deep in the.
You could have ever done it before, you won't be able to.
Yeah.
How long is I believe you say?
So then, do they also then ligate the original left knee?
That was a discussion that we had before this. So he said their experience is mostly is to bypass.
I mean, you can even see on the cat that it looks like it's
You can see
the obstruction, yeah.
So one option is you can do like on a bar.
But I mean, it's just like visually, that's what it is. I mean, we have a patient before that we were like thinking something like that. We were like increased pulmonary pressure. And it was like anomalous as well. So it was like and it was getting compression just for increased pulmonary artery pressure with the patient didn't use oxygen. So in those cases, what are you gonna do in this situation? I mean, you cannot. It's too deep to try to do something. At least that's what we were.
That's what, yeah, they said.
That was one question.
Putting it with its net.
So there is some data that compares alcohol septal ablation with endocardial RF ablation, and the outcomes are actually not too dissimilar for long-term septal reduction and symptomatic septal stroke. So there's some data with that, and there's also some exploratory data now using PFA, which theoretically is going to be less effective, though people claim because of the lesion size that actually does cause septal regression. That's early. The problem with that, of course, like alcohol septal ablation, is that you need conduction system disturbances and things like that. If he does warrant an ICD, it may not matter. He may see maybe looking at the device, but it's something to think about.
So just to kind of summarize our case, this was a nice example we had of the utilities of multimodality imaging and procedures that we have available, and to really help this diagnosis. And then we did repeat an echo on the patient post-procedure. He did not have any evidence of LVOT obstruction. So ultimately he was discharged home. There was a discussion about ICD, which we just mentioned. So he was sent home with an event monitor and was later evaluated. He had no evidence of any arrhythmias. So ICD is not recommended at the time. Had all these other interventions as well. Any questions from the applicants about the case? If not, thank you guys for joining us. We'd love to have you here at UIC. And I think for the fellows here and the faculty, thank you for joining us. And before we go into the discussion about a little more about UIC. Thanks. Good job with you. You guys want to take like a quick 5 to 10 minute bathroom break, and then break, and be back at 1.
Mary, are you ready to begin?
We're going to give the applicant a brief break.